Good morning, dear colleagues, dear chairman. I would like to thank the organizing committee for the opportunity to be here among you today, and I will speak about the so-called medical therapies in Peyronie's disease. This is my disclosure. What we have to know about Peyronie's disease is that it has two distinct phases, what we call the active disease or the acute phase of the disease and the stable disease. The active phase of the disease is mostly characterized by pain, either in erection or not, and the ongoing process of the inflammation which causes the induration and finally the plaque. In the stable disease, pain might not be present in most of the cases, but it's a stable disease, the plaque has formed, and in most of the cases, the plaque has been ossified. When in the stable phase, nothing mostly can be done in terms of medical treatments. And if we look at the diagram below, medication is mostly beneficial in the acute phase of the disease. Mechanical therapies and intralesional therapies for the whole phases of the disease. Iontophoresis and topical therapies have a small meaning in the acute phase of the disease, and once we are in the stable phase, surgery might be the only option. So the purpose of the treatment is mostly in the acute phase of the disease is to target the pain that the patient feels, to prevent the plaque formation, to prevent the growing of the plaque, the penile size alterations in terms of length, to prevent the angulation of the penis, to prevent erectile dysfunction, to prevent the distress of the patient, and finally the disease progression. So this will be the checklist that we will see and compare all the available medication. These are all the regimens that we have in the literature, and let's see what's the evidence for every one of them. Vitamin E, I think it's the most common regimen used by urologists worldwide. The rationale is that it's a natural antioxidant with anti-inflammatory properties targeting the TGF-beta-1 inhibition. But the efficacy of vitamin E has been shown to be none if we choose the best quality of studies, although you will find many conflicting data in the literature. But note that it might have a potential effect only in multimodal settings. Colchicine is a historical treatment for Peyronie's. I think nobody uses it anymore. Again, conflicting data in the literature. If we stick to the highest quality of evidence, then no benefit comes to the treatment of Peyronie's disease. Tamoxifen, it's a SERM, a selective estrogen receptor modulator that has been used for many years in treating Peyronie's disease. Again, conflicting data in the literature. If we stick to the highest quality of data, no benefit in treating Peyronie's disease. But only lately, in 2019, there has been a very good study that shows that it has a great synergistic effect when combined with PDE5s in treating Peyronie's disease, and that might be a therapeutic regimen to challenge in the future. Carnitine, again, conflicting data, no benefit in treating Peyronie's disease. Potaba, that most urologists also use, and with anti-inflammatory and anti-fibrotic properties. It has been shown in various studies that it diminishes pain, the plaque size, and the angulation. If we stick to the high quality of data, then it has been shown to decrease the plaque size and to prevent any more progression in angulation. It does not straighten the penis. Of course, it has many side effects, mostly gastrointestinal side effects, and we have to note that in all of the studies there have been many dropouts in the patient, mostly because of these side effects and the dosing scheme. The patient has to take Potaba 3 or 4 times a day. Pentoxifillin is one treatment that's really promising. It's a non-selective PDE inhibitor, downregulating the expression of TGF-beta-1. It has been shown in average and good quality of studies that it decreases the penile curvature, decreases the plaque size, and it prevents further progression in angulation. This particular target is when somebody stops the treatment, if the disease will progress or not. Mild side effects, what we mostly know from the PDE5s, GI-related headache and blood pressure in these patients should be monitored. How about PDE5s? I think most of us in the last years give some kind of PDE5s to all our Peyronie's patients, and the rationale behind this is the antifibrotic activity of NO and cGMP, which reduce the oxidative stress. In various studies, PDE5s have been shown to decrease the plaque size angulation and treat the pain, but mostly PDE5s have been shown to improve the sexual function as they should in these patients, and nothing more to do with the natural history of the disease itself. We know the potential side effects, and there may be a regimen especially beneficial in multimodal settings as well. L-arginine has been tested only in animal models with modest results, and that might also be something to challenge in the future. And let's go to the coenzyme Q10. A natural antioxidant with anti-inflammatory and antifibrotic properties, which in good quality of studies compared to the others has been shown to reduce the plaque size, reduce the angulation, reduce the deformity progression, and also improve the sexual function. And that's also something that we have to challenge in the future, also in multimodal settings. Omega-3 fatty acids, no benefit at all. And I will close this section with two things. One's called propolis. It's a bee-derived substance. It's all natural and contains flavonoids such as quercetin, which are natural antioxidants, and also bilberry. It's a type of blueberry, also with many flavonoids and phenolic compounds, also natural antioxidants, which have two studies from the same Italian group from Paulis, which have been shown to be effective in all stages of Peyronie's disease and all the targets of the therapy. Potential effect also in multimodal settings. So let's go to the mechanical therapy. How about vacuums and extenders? The rationale behind the use of extenders mostly is something called mechanotransduction. This is how external forces that are applied to a tissue affect the tissue in a molecular and a cellular level, improving cellular proliferation and extracellular matrix remodeling. The efficacy in various studies is very good, also in the acute phase and the chronic phase of the disease, but it has been shown in the good quality of studies and the meta-analysis to reduce the angulation of the penis and also to improve the stretched penile length, to restore a bit the length that has been decreased due to the Peyronie's disease itself. Side effects: discoloration, decreased sensation of the penis and the glands, some penile discomfort that all resolved by itself after removing the device from the penis. Also potential efficacy in multimodal settings. We don't have an established protocol for the use of these devices, and it has been shown that they present with a dose-response curve, which means that if the patient uses these devices for a longer time every day, the better the result will be. But we don't know what's the maximum time that can be applied every day. Shockwave therapy. Again, we have many studies with many good results in the first studies. In the meta-analysis, the use of the shockwave therapy in treating Peyronie's disease only are effective in terms of pain and also improving the sexual function. If we look at the recommendations from the ISSM, they should not be offered for treating Peyronie's disease, only treating the pain in the acute phase of Peyronie's disease. Verapamil gel was used historically with the rationale that the calcium channel blockers have an anti-inflammatory effect, targeting extracellular matrix production and regulating the fibroblast function. When using the gel, it has been shown that no concentration of verapamil can be achieved in the tunic albuginea, so no benefit came from that, and that's how iontophoresis came to the game. Iontophoresis makes sure that the concentration of the substance is higher in the target tissue, maybe 1,000 times longer. So using iontophoresis with verapamil, we have good data that support that it reduces the plaque size, reduces the pain, and reduces the angulation. Note that when iontophoresis was used with saline, the same results were achieved, meaning that the good result may have something to do with the electric current in itself and not with the verapamil, the substance, and the dexamethasone used in these treatments. So if we go back to the initial checklist, for pain, we can give practically anything. We can give simple painkillers. We can use also shockwave therapy, although it's a bit expensive. And we also have to tell the patient that the pain will go away by itself sometime. How about preventing the plaque formation? We don't have any evidence for that some of these regimens have to do anything with the natural history of the plaque formation. How about the plaque size, potaba, pentoxifillin, coenzyme Q10, and iontophoresis? About the penile size alterations, I think it's rational to use a traction device. About the angulation of the penis, pentoxifillin, Q10 traction and EMDA have been shown to improve the angulation. About the erectile dysfunction, coenzyme Q10 and PDE5s. About the distress that the patient feels, give something and deal with the patient. Don't tell the patient, come back after 6 months, come back after the pain goes away. Once you have a stable disease, then we can do something and we will go to surgery. It's imperative that you do something in the acute phase. And about disease progression, coenzyme Q10, potaba, and pentoxifillin have been shown to have an effect. So what's the problem in all of these regimens? All of these studies, even the good ones that stood out in this presentation, are low-quality studies, and the problem lies mostly in the materials and methods. Although they have to do with Peyronie's disease, in most of these studies, there was no differentiation between the acute phase of the disease or the chronic phase of the disease, and also most of these studies did not have any radiographic data. Let's go back to the previous presentation, and if we go back to the natural history of the disease, once we have a well-established and ossified plaque, none of these medical or mechanical therapies will be of any use. And also, there is the great variability of the disease's natural history. In some patients, it will get worse. In some patients, it will stabilize. And in some patients, it will resolve by itself. But we don't know when this will happen and to which patient this will happen. So we have to be very careful about the patient selection, about the disease phase, and maybe we will have to start differentiating patients by radiographic criteria and not only time and symptom criteria. We'll have to choose very carefully what the endpoint will, in every study will be, and we have to make sure who will be responsible for the end result. If there's a good result, it's the regimen that we have challenged, or maybe the natural history of the disease would have resolved by itself, even if we didn't do anything. So what's the solution? We have to go back to the bench and find some approaches and find some drugs and find some modalities using a target-based approach, targeting molecular pathways and targeting specific spots in the pathophysiology of the disease, and also using greater phenotypic screening assays. And remember that the phenotypic screening assays gave us back the tamoxifen in conjunction with PDE5s, which have been shown to have a great synergistic effect. And let's go also to the bedside, as the motto of this conference is. We have to use multimodal approaches. Use any of these potentially beneficious regimens, use traction devices, use iontophoresis, use shockwave therapies, all of them in conjunction in terms of trying to find the best therapy in every individual patient. Thank you very much.
From the audience, any questions? So, as we all know, treating Peyronie disease is a strange situation. Probably most of the patients that they come, they don't have one. They have pain. They have a plaque that's beginning to formate. They have a curvature. Okay, let's stick to these three. You are right. We will at the end we will finish in therapies that have a multiple variety, because otherwise I don't think there is a solution. If you have now, let's give a take-home message. In your office comes a 50-year-old with pain, plaque formation, and curvature. What's your treatment?
I personally use traction devices in all of the cases that come for 1 or 1.5 hours every day. I use PD5s in all of the cases, and I use pentoxifillin in all of the cases. In terms of if there's a plaque or not, if it's an ossified plaque, I don't use iontophoresis. If there is something like a septal scar or an ongoing plaque formation or a thickness in the tunica albuginea, then I also challenge iontophoresis.
Thank you very much.
I have a question, George. Thank you for the excellent presentation. I was going to take that even further. When you counsel your patient in the office and you start him with multimodal therapy, like the one you just described, and he asks you, what are the chances that I'm going to have surgery after this? What do you reply? What did you reply? I mean, what percentage of patients starting on Peyronie's disease will end up having surgery?
I don't give them any percent at all. I try to explain that there is a high variability of the disease's natural history per se. I am telling him that the modalities that I will be using in him, I personally do not know what the effect will be, but we have to try for the best. And most of the patients are really happy that they're able to do something in order to prevent the surgery. And one parameter that I did not use is that most of these modalities, and especially traction devices and vacuum devices, have the ability to prevent the surgery. If you have an angulation of 45 degrees, and after 6 months of traction therapy, you get the angulation down to 30 degrees or 25 degrees, then the patient is totally satisfied and you have prevented a surgical operation.
Great. Thank you very much.
Thank you.